just a few center updates. Thank you all for being here. The Society for Maternal Fetal Medicine conference, as you know, is going to be taking place in about a month, and we will have an oral presentation and 9 poster presentations at that meeting. And I know many of us are planning on being there, so should be a great showing and a really interesting meeting. Next month, our featured speaker is Dr. Avi Shore. He's the director of the Women's Health Innovation Center and the Deputy Chief Transformation Officer in the Shiva Tel Hashomer Hospital in Israel. And he'll be talking about the convergence of remote care, artificial intelligence, and precision health in maternal fetal medicine. And Avi had spent some time here at Stanford several years ago and has continued to collaborate with many of our faculty here. So I will have Dr. Lyle present our featured speaker for today, who
Great.
also spent some time here.
Yes, thank you, Yasser. I am so pleased to introduce Dr. Sarah Osmundson. She's today's speaker for the Dunlevie MFM Center for a speaker series, and to welcome her back to Stanford, at least virtually. Dr. Osmundson was a former Stanford MFM fellow almost 10 years ago, where she also received a Master's of Science in Epidemiology and Research Design. She received a BS in Anthropology at University of Illinois. Upon graduation, did Teach for America in Chicago Public Schools for 2 years, received an MD from University of Illinois, Chicago, and then conducted her OBGYN residency at Northwestern. And as I mentioned, MFM fellowship at Stanford. And then she joined faculty at Vanderbilt in 2015. She's currently an associate professor of obstetrics and gynecology in the Division of Maternal Fetal Medicine at Vanderbilt, where she also serves as vice chair for research. She's received a lot of awards along the way, including teaching awards, where at Stanford she was a Muggeridge Fellow, received a training support award. She's been a Birch Scholar. Her paper on post-discharge opioid use after cesarean was selected as a CME paper for ACOG, and that's a pretty big deal. And I think we'll hear more about the contents of that paper today. Her research, among other things, examines postpartum care for pregnant patients, including particularly opioid use and prescribing, management of hypertension, and developing novel models of care, as well as the impact of medication exposures during pregnancy and postpartum. She's funded by the NIH through NIDA, NICHD, and NINR. Nationally, she serves as a board member for the Society for Maternal Fetal Medicine, and she previously served on the SMFM Publications Committee. And today she will focus, as I mentioned, on her practice-changing work, predicting post-opioid discharge use after childbirth, matching prescribing to actual use. And I do have to say this has truly been practice-changing and so important. So thank you, Sarah, for joining us today.
Well, thank you very much for having me. And I'm so excited to see some of my fellow collaborators in this space on the call today. So I'm looking forward to a healthy discussion about things at the end. Let me see if I can get this. All right. Can you see my main screen?
Yes, we can.
Okay, okay, great.
We see the presenter view.
Oh, you see presenter view. Okay, let me try this.
Please, yeah.
Let me swap it again. Oops. Okay, better?
Perfect.
Now? Okay, great. All right, so I will be talking about post-discharge opioid use, really focus not on the inpatient experience of pain and opioid use, but what we do when patients go home from the hospital. And I have 2 primary objectives today. First is to really understand the complex and competing demands that are at play when we prescribe opioids after cesarean birth. And then to describe different prescribing approaches and with both their strengths and their weaknesses. So I think the main kind of question to start with is, what are the major issues that shape opioid prescribing after cesarean delivery in the United States? And I think it's important to kind of put all of this in context first. So these are data on surgeries in the United States that were published by HCUP in 2020. And at that time, there were a little bit over 100,000 cesarean births performed in the US. In comparison, the second most common major surgery is hip arthroscopy, and there were roughly 400,000 procedures. So this means that cesarean delivery is 2.5 times more common than the next most common major surgery. And that has really important implications for what happens to patients after cesarean birth. To further emphasize this fact, I think it's worth considering that about 85% of women will experience childbirth at some point in their lifetime, and about 1/3 of them will have a cesarean birth. So if you do the math, roughly 25% of all US women will experience cesarean birth at some point in their life. And this, I think, emphasizes the fact that it's really important to get this right. And the small things are big things here. So controlling pain and avoiding even small downstream effects related to cesarean are very important because the implications are huge. And, you know, I think to kind of expand on this, this is why even having these small amounts of opioids left over after cesarean can be such a big deal. These are data from the Substance Abuse and Mental Health Service Administration, or SAMHSA. They conduct annual surveys of households in the United States using probability sampling, where they're trying to obtain a representative sample of the US population. This is cross-sectional data, so it's not perfect, but it does give us like a reasonable estimate of substance misuse behaviors. And misuse in this context is defined as taking a prescription in higher amounts or longer than recommended by a physician, or using someone else's prescription, or using opioids to get some sort of pleasurable experience. So in 2022, 3.2% of adults reported misusing opioids. And this chart just shows us the breakdown of where prescription pain medications were obtained for the most recent reported misuse episode. And you can see from here that really the vast majority of opioids were obtained either from a relative or a friend who had been appropriately prescribed opioids, or they were prescribed for another reason and then misused. Even the appropriately prescribed opioids can become major problems. In addition, some women will develop problems associated with opioid use after cesarean birth. And this is a figure from one of our studies using data from Tennessee Medicaid, and it shows the cumulative incidence of serious opioid-related events in the first year postpartum by the number of prescriptions that were filled in the postpartum period. And we define serious opioid-related events as persistent opioid use, which was kind of the majority of events, but also a new opioid use disorder diagnosis, new buprenorphine use, drug overdose, or death. And in our Tennessee Medicaid population, the absolute risk is small, so about 0.84%. But because childbirth is so common, if we extrapolate this to our population level, then we would estimate that this type of exposure could lead to more than 21,000 new cases of persistent opioid use annually. And you may look at this and wonder, well, maybe it's just like our high-risk Tennessee population. We're in the South. These are patients with Medicaid insurance. But this is another study out of the Michigan group that use the Optum Data Mart set, which is a sampling of commercially insured patients in the United States. And in this study, they found that the frequency of persistent opioid use was even higher and estimated to be around 2.2%. So there are potentially serious consequences of opioid prescribing that even with small frequencies can have profound effects at the population level. So we can easily address overprescribing by simply prescribing less, giving few or no opioids at the time of discharge. But we have having patients with poorly controlled pain has potential other consequences, both for patients and I'll also argue for providers as well. So this is an older study by Eisenach et al. From 2009, but it's frequently cited. And the authors followed about 1,200 patients after vaginal and cesarean birth for eight weeks. And they, within 36 hours of birth, they queried women about their acute pain scores, as well as their history of pre-existing pain. And they defined severe pain as a pain score of 7 to 10. And then they, again, at 8 weeks, asked them what had been their average pain score for the past week and gave them a depression screen, the EPDS. And they defined persistent pain as having basically any pain or pain score greater than 0 at 8 weeks. And women with severe acute pain in that immediate postpartum time period, and that was defined, again, that pain score of 7 to 10, had a 2.5-fold increased risk of persistent pain and a 3.4 increased risk of postpartum depression compared to those with mild pain. So these are really kind of, I think, intriguing data that suggest a link between poorly controlled pain and depression. But it's really hard to, again, like assign causation in these type of studies, because I think there are a lot of questions about whether acute pain causes persistent pain or depression, or is there another pathway where women with underlying or at risk for depression, whether diagnosed or undiagnosed, experience more pain and have higher risk for persistent opioid use. And the really big question is whether if we reduce acute pain after surgery, after cesarean, can we reduce persistent pain and postpartum depression? And these are, I think, are really kind of unanswered questions right now. But we do have some other great studies, some of them from Stanford, that look at pain and like the average pain experience in the postpartum period. And so these are two great studies from our anesthesia colleagues, which document what the pain experience looks like in that like first 6 to 8 weeks. So this study on the left by Booth et al. Followed 530 women for 8 weeks after cesarean using daily pain diaries. And as someone who has done that in my own practice, I can say that getting patients to do these daily pain diaries is very challenging. So I applaud them. Using these data, they identified 6 clusters of pain recovery trajectories. So kind of like 6 bins that we could put people in after cesarean, which are represented by these rainbow lines. And most people had a fairly quick decrease in the amount of pain that they experienced. But there is this cluster, the 6th cluster, where pain remained high and took a lot longer to decrease. And the authors then also noted that there were certain features which determine which cluster patients belong to. And these features included predictors like depression, perceived stress, smoking, average pain scores on postoperative day 1, which are features that I think we see over and over again that also will help predict pain, opioid use, and long-term problems associated with opioids. They did estimate in this study that about 9% of women would have persistent pain after 2 months after cesarean based on these trajectories. And then on the right, this is another great study done by Ryu Komatsu, who was a fellow at Stanford when I think he was a fellow when I was here with Dr. Carvalho and Dr. Flood. And this study documents the time that it takes for nulliparous women to be pain and opioid free after childbirth. And they followed 213 women with daily assessments around their opioid use and pain. And they found that the median number of days required for both pain and opioid-free functional recovery were about 19 days after vaginal delivery and 27 days after cesarean. But they also, I think the interesting part is noting that the interquartile range, so that 25th and 75th percentile, was fairly wide. So for women with a vaginal birth, it was 11 to 25, and for women with cesarean, it was 19 to 40. So that's a fairly wide range of experience. And kind of one of their main conclusions is that there is this wide range in pain experience after childbirth. And we see this in the studies that we've done at Vanderbilt. I've combined data that we have from 5 different studies. This is not perfect data. There are different things that went on in these studies, but in all of them, we've we've looked at discharge opioid use. And so we have 945 people with data on that. And I think the thing that we see in all of these studies is that there is this group of patients who use all the opioids that we prescribe, regardless of the amount that we prescribe them. And they're also a lot more likely to state that their pain was poorly controlled or they should have received more opioids. So I think one of the questions here is why not just prescribe less opioids and let women come back and get a refill if they need it? But I would argue that this is actually a fairly challenging process, especially as we've had more both state and federal restrictions on opioid prescribing. So for example, in the United States, we have 34 states that require patients to come in for a physical exam before receiving an opioid. And this can be especially challenging for our patients who live 1 to 2 hours away and have a newborn at home and have transportation issues getting to the hospital. They also require in 23 states that you use tamper-resistant forms. So this makes electronic prescribing challenging in some locations too. In Tennessee, and I'm imagining in California as well, there are state restrictions on prescribing. So we are not allowed to prescribe more than 180 morphine milligram equivalents or MME in a single prescription. We can prescribe more, but then we have to do an informed consent process, which is burdensome and time consuming. Opioid prescriptions are limited to 3 days, and pharmacists do have discretion to partially fill a prescription if they choose to. So I would argue that using refills as a measure of dissatisfaction or pain is kind of inadequate, because for some people, it's extremely challenging to come back to the hospital to see a physician and obtain a second prescription. And then I think something that's not discussed a lot, but is also extremely important, is clinician acceptability and buy-in for reducing opioid prescribing. I currently practice in an environment where I'm not the person answering phone calls in the middle of the night when somebody has a problem with pain or their incision or things like that. But in a lot of other practices, especially in private practices, and I think I saw Dr. Wachtel on here, I was the person answering a lot of these phone calls when moonlighting back in fellowship. And I can attest to the fact that getting woken up in the middle of the night because someone didn't receive enough medication or is having problems is not something we want to see happen. And so there are real reasons to try to not underprescribe or undertreat pain. We did a small survey on this. It was a survey of our Vanderbilt faculty, which include people who practice at our main site, but also in satellite locations and more kind of private practice environments. And then also another hospital, large hospital, where we have multiple practices that deliver out of there. And we asked questions about whether clinicians believe that their reputation or their compensation depends on patient satisfaction. And a majority, not surprising, I think, but a majority of clinicians endorse that. And then 90% of clinicians say that they would like to limit opioids prescribed after childbirth, but only if it would not affect patient satisfaction. And so, I think it's really important to consider what happens when a patient is unhappy with their pain control and unhappy with how they were prescribed medications after having a major abdominal surgery. The other part of this is that and I'll go into kind of what the approaches are to prescribing, but some of these approaches are quite complex. And trying to do that when you're discharging 10 or 15 patients after delivery can make that, even adding 1 or 2 minutes onto the time required to do that, the standard discharge can add up to a lot of time invested by clinicians, and that may not be something that's really feasible within our current practice landscape. So next, I'm going to talk about what approaches are out there for prescribing opioids at discharge after cesarean. We've, I think, accumulated more data and more studies in the last 5 years about different ways that we can try to prescribe opioids. And I'll describe sort of several different approaches. The first approach that we've seen in the literature is this like tiered opioid prescribing. So looking at, and most of these depend on, are really geared around inpatient opioid use. So we're looking at inpatient opioid use as a predictor of what your outpatient use will look like. And so, for example, this is a study that was published in 2019 that classified patients into 3 categories. So either they used no opioids during their inpatient stay, they used no opioids in the past 24 hours when they were assessing discharge, and then patients who had used some opioids. And based on this, they then gave them different types of discharge prescriptions. And not surprising, in all of these studies, we will see that there are less opioids prescribed because we're doing something different than just prescribing everybody the same thing. The other approach is to use a shared decision-making process. And this is a study that I'm sure many are familiar with, and Dr. Bateman led at Brigham. And this is really allowing patients to select the number of opioid tablets up to a fixed amount. So in this study, there was an educational tool that was given to patients, and that went over like the side effects of opioids and the potential for abuse. They also told patients that while normally patients at the institution receive 40 tablets of oxycodone 5 milligrams, most patients were only using about 20 milligrams. And then patients were allowed to select between 0 and 40 tablets. So in this study of 50 patients, when they were allowed to select their number of tablets, the average number of tablets selected was 20, which is significantly lower than what the historical controls had been. I think my one big question is always just the time investment that it takes to do this. And I don't know how much has really been done in some of these other studies to quantify the time required or invested on behalf of clinicians. But it certainly seems that when patients are given some information about this, that they will select less than what they could have received. And then there is one study that looks at prescribing no opioids. In talking with colleagues and friends in Europe, it sounds like in many parts of Europe, leaving the hospital without an opioid prescription is actually the most common thing. Although I would just sort of caution to say, like, so, you know, a lot depends on how long patients are staying in the hospital, what their postpartum support once they go home from the hospital looks like. I would say even like maternity leave and things like that can factor into that entire experience. So these are not entirely equivalent scenarios, but I think it is really important to consider that maybe opioids are not required at all. So this is a randomized controlled trial that was done in Texas, looking at ibuprofen and acetaminophen versus ibuprofen and hydrocodone. And they found in the, it was an equivalence trial. So again, looking to see if these were kind of equivalent approaches for opioid prescribing. So they found, interestingly enough, that, well, they found that less opioids were used in the, obviously in the ibuprofen and acetaminophen arm, and that 73% of patients were able to use no opioids at all. But there were a substantial number of patients in this arm that had to get rescue prescriptions. So that was 17 in the non-opioid group. And interestingly enough, they had lower mean pain scores in the non-opioid use group, albeit with the same amount of ibuprofen and acetaminophen use. So I think it's a really interesting study. And one major drawback is it's not blinded, and the patients who sort of select to be in the study may be very different than our general population, but I think it really is provocative and sort of thinking about not using opioids at discharge. And then the final category that I would discuss is individualized opioid prescribing. And this has been kind of the major body of work that I've focused on. But there are multiple different approaches to individualized prescribing that have now been published. And I'll just kind of run through a couple of these strategies. So one that has been used in at least two studies, two obstetric studies that I could find, is the 5 times rule. So this is basically looking at the total MMEs used in the past 24 hours prior to discharge, and then multiplying it by 5. So for example, in this case, if you had had 3 tablets in the last 24 hours, you would receive 15 tablets going home. Another approach is this 20% reduction, which is used in the PACT trial, which I'll discuss a little bit later. It's the trial that will probably soon be published. So in this situation, they again calculate the total amount of MME used in the day prior to discharge, and then do a 20% daily reduction up to 20 tablets. And so I tried to do this myself to figure out the calculation, and this is roughly what it looks like if you do this like 20% daily reduction all the way down to, I think they said, what was like a half tablet of oxycodone. So in this situation, 3 tablets of oxycodone use would translate into 10 tablets of oxycodone prescribed at discharge. And then the final one that has been published on is our work, which basically took our what we observed for use in our population and created a very simple, basic linear regression formula to then estimate the amount of opioids needed to be prescribed. And so in this case, we again looked at the total amount of opioids, not quite in the last 24 hours, but we selected a kind of a time period where everybody's in the hospital, which is 24 to 47 hours, and then use this formula to calculate the amount at discharge. In our sample, 3 tablets of oxycodone would become 12 tablets of oxycodone. So just to sort of summarize these three different approaches that have been described, I think it's important to think about, like, where did they come from? The 5 times rule, I cannot find any data. Like, I think that it's just like maybe expert opinion that said, well, let's just give 5 times the amount. The 20% rule has one citation for it that goes back to an article that is a review article that focuses really on how to taper opioids for patients with chronic pain. So it's a very different type of scenario than what we're dealing with in an acute pain setting after cesarean birth. And then there's our formula that derives from a linear regression model. But I will readily admit that this is not a very good approach. And so, the question, well, what's so bad about linear regression? And I would say that there's really nothing in pain after cesarean or opioid use after cesarean that is linear and follows a linear pattern. In fact, like, again, this is the data from Stanford here, looking at pain resolution and opioid cessation, and nothing about these patterns follows a nice, like, linear straight line towards not using opioids or having pain resolved. And we have some suggestions for that. The other important thing to just discuss is that there are factors other than inpatient opioid use that are also associated with discharge opioid use. And these are just several of the ones cited in the literature, such as pain prior to cesarean, the incision type. We see a lot of associations between depression, pain catastrophizing, anxiety, and increased opioid use, as well as tobacco use. And then I think another really big one is the more you give people, the more they use. I think there's definitely something about, like, using a portion of what you're prescribed and maybe self-regulating based on the overall amount that you're given. Not sure why that happened. So our research is focused on a lot of whether we can predict discharge opioid use after cesarean. And this was a paper we published in 2022, whose purpose was to develop and validate and calibrate a prediction model for post-discharge opioid use. It was an observational cohort of 459 women, where we did surveys on postoperative day 1 and 14. In this study, we gave everybody 30 tablets of hydrocodone, which I sort of now look at and say, like, that seems like a lot. At the time, that was kind of our standard dose, or when we were preparing this study, that was our standard opioid dose. Now I would say at our institution, it's somewhere between 12 and 15. So we've really overall kind of changed that. We sought to use only data that was available at the time of discharge so that it could be used in a clinical setting. We confirmed all the prescription fills with our prescription monitoring database. And then our outcome was the total amount of opioid used of the discharge prescription within 6 weeks. And these were just the predictors that we looked at that had previously been described in the literature that we examined as predictors of opioid use. We constructed a prediction model using this semi-parametric proportional odds model. And one of the advantages of this type of model is that it allows for arbitrary outcome distributions. So you don't have to have this like linear progress of opioid use. And then we looked at all those covariates and ranked them a priori in order of our hypothesized association with the outcome. We used a couple data reduction techniques to avoid overfitting, and this included creating these clusters of predictors that were part of our principal components analysis, as well as several predictors that were just individual. And we created 3 models, one that used all the 34 predictors, one that used only predictors that were available in the electronic health record. And that's to try to extrapolate to a clinical setting where we are not having to ask patients questions. And then finally, we used a reduced model where we added in predictors to try to achieve a performance that was at least 90% of the performance of the full model. And so, oops, backwards. I won't get into kind of the details of how we assessed everything other than to say that we did internal bootstrapping to validate the model. And this figure helps to kind of, I think, visualize what we found. You know, again, I think inpatient opioid use, and this is opioid use in the prior 24 hours, was really the most important predictor. So very in line with what other studies have used, but it's not the entire model, and it doesn't explain all the variation that is out there. We did find that the full model, or I'm sorry, the reduced model performed almost as good as the full model. So these are just some of our indices for the model. And the reduced model ended up using only the top 3 predictors. So opioid use in the 24 hours prior to discharge, depression, and tobacco use. And then we also examined in more detail this question about where the sources of information. So some approaches are using the total amount of opioid prescribed in the last 24 hours. Another approach would be sort of looking at like an average amount of opioid, or the MME per hour of inpatient stay. And then we also looked at, we had asked a lot of questions about depression, which I think we ended up finding like almost double the amount of depression and anxiety with our questionnaires versus what we could just obtain from the electronic health record. And we did find that the model that used all the sources of depression, as well as the model that used just the opioid in the prior 24 hours, performed better than the other models. And then we went and created a nice little calculator that's available online where you can import the number of the amount of opioid used in the prior 24 hours and whether the patient has depression or tobacco use. And it will give you, it gives you the predicted mean for that population. You can actually set this model differently. Like if you wanted to predict the 25th percentile of opioid use or the 75th percentile of opioid use. So depending on how liberal you want it to be, You could specify that, but the model we have available online gives us the mean. And then I kind of want to just close out by mentioning the PACT trial. So this is the prescription after cesarean trial, which is a large randomized trial conducted by the Maternal Fetal Medicine Unit Network across multiple sites in the United States. And this was an initiative, I think it was initiated by the HEAL initiative at the NIH. And they came, my understanding is they came with sort of a protocol to begin with. And the intervention was several interventions. So it encompassed an individualized opioid prescribing, that 20% reduction daily, education about post-cesarean pain and opioid use, and then a shared decision-making with the patient versus a fixed opioid amount of 20 tablets, I think, of oxycodone, 5 milligrams. And it's a non-inferiority study with the primary outcome being moderate to severe pain on the moderate to severe pain, which is basically a 4 or greater on that pain score. I do think the challenge of doing something where you've combined 3 different interventions into one is that you don't know which of these made the most important difference. And I do think each one of these things has trying to implement each one of these things has some could have serious impact on the discharge environment for patients and the time that it takes to do this. At our institution, we try to discharge everyone before 11 a.m. There's a big push to do that, and really kind of adding in things that potentially take time or require our nurses to take time to do that could have substantial effects. So I think it would be really nice to know which one of these is the most important part of that. And I don't think that we're going to know that with the study. So sort of conclusion and summary, I think it's really important that we get this right. I think, we may look at there are a lot of studies out there that look at discharge refills or refills after discharge, look at more inpatient measures of things. But I think it's really, really important for us to be both examining the amount of opioid that's left over after cesarean that's available in the community to be used for other things, and the pain that patients experience. And I think a lot of studies do not examine. They may just give you a pain score during a certain time period, but they don't really look at other measures of satisfaction. And if we are to implement something at a national level, I think, any measures of dissatisfaction will eventually come back to haunt us. And it's really important for us to try to get that number of leftover opioids as close to 0 as possible. So even the difference of 1 tablet could have kind of profound implications for our population health. I already mentioned pain and patient satisfaction matter a lot. And I will argue that clinicians' time matters a ton too. And so as we move forward in this realm, I think it's really, really important to think about implementation. As someone who has tried to who has used even an online calculator to calculate what we think patients should go home with, I can tell you that the process of going into the MAR and trying to identify all the opioids and what the time period was 24 hours prior, that's time consuming and a pain in the butt to do. And so these kind of things really need to be automated. And this is where I think kind of bringing in our bioinformatics expertise to automate some of these processes will go a long way. But if we don't offer that at the same time that we recommend doing these things, I suspect that many busy clinicians will say, this is just too much. I'm going to give my best guess. And we'll end up kind of back where we have been, which is giving everybody roughly the same thing. So I think we have a couple minutes left, and I would love to hear any questions or thoughts or opinions that you have.
Thank you so much, Sarah. That was great. I asked people to put them into chat, and we have one in chat I'll lead off with, it's Dr. Danielle Pinelli, who's one of our MFM Warhurst scholars with a special interest in depression, asks, first, great work. Apologies if I missed this. For your studies with depression, really, when was it ascertained? Cross-sectional during hospitalization versus history of depression versus further postpartum.
Yeah, that's a great question. And I didn't even get to go into the details about depression and anxiety. So if we were looking in our prediction model, we were looking at any diagnosis of depression during pregnancy, or patients were asked about depression too at the time of the survey or discharge. So it was a very broad definition. Versus just looking in their chart to see if it appeared in the problem list and there was like an ICD-9 or 10 code associated with it. So when we use that broader definition, which included, I think we had a PHQ-9 in there, or one of the PROMIS surveys about depression. I think it was PROMIS survey on depression. When we use that broader sort of picture, that the model performed better. So I do think it really raises a lot of questions about how we assess and document depression. And if we are thinking about using some of these more complex models that incorporate depression into the model, then we really need to collect that data better.
Great, thank you. And can you comment a little bit though, when we're talking about depression on the chicken and egg here? I mean, you had mentioned that we know that increased pain can increase depression. Certainly, we know that in somebody who has depression, that decreasing the pain, is it only that it doesn't make depression worse, or can you make it better in somebody who?
Yeah, and I don't know. I wish Dr. Bateman was here still, because I would love to, or actually, I don't know if Brendan can comment too. Like, I don't know that we know. I do work with Stephen Burrell, who does a lot of work on chronic pain and biomarkers for chronic pain. And he would argue that there is, like, depression itself alters these biomarkers and enhances or alters the pain experience afterwards. So, it may, one of my concerns is we look at these lists of things that predict pain, they also predict persistent opioid use. So are we harming patients by potentially giving them more opioids? Like patients with tobacco use disorder or patients with depression, could we harm them by giving them more opioids? And his argument is that they actually have a very different pain response and actually do need additional opioids in an acute pain setting. But I would say that's very, whether you can alter that by treating pain better acutely is still very, very much up in the open. And whether it's the chicken or the egg, I'm not sure.
Great. Thank you. And I don't see any more questions right now, so I'm going to take the prerogative to ask one more. Can you comment on I imagine this is an area where there's a lot of bias in profiling against patients. And can you comment a little bit on really best practices? I think you've kind of covered this, but I think it's a really important point, like best practices to just reduce, just sort of profiling people and saying this person really doesn't need to treat pain. We know that there have been particularly racial ethnic disparities whose pain is not treated as well. So if you could say a little bit about that.
Right. I mean, I think, my hope is that sort of using some of these calculators may help us avoid some of that bias. I do think, and this is this whole separate topic, we definitely probably undertreat pain in women with chronic opioid use or opioid use disorder, even when they likely need more to compensate for their exposure previously. And I do think it's interesting in having in one of these studies, I made a lot of the phone calls talking to people. And I remember having a physician who participated in the study, whose husband was a urologist, who was really concerned about overprescribing and addiction and things like that. And she said, I had a ton of pain. I had 30 tablets. I used every single one of them. I needed every single one of them, but I was really trying to decrease, be very conscious about doing it. And I do think there's just a group of people that have a different pain response, and we have to be healthy and respecting that and not dismissing it, but also like be very cautious and like maybe following those people more closely, or if they come in and ask for a second prescription, being very careful about how they're prescribed later on.
Got it. Thank you. Well, we are at the top of the hour. Sarah, thank you so much for coming today. We are so proud of to be able to call you one of our MFM fellow graduates and watch as your star continues to rise. But thanks for sharing your great work here, and it's much appreciated.
Thank you so much. Great talking to you.